Okay, good afternoon, everybody. It's Sebastiano from NOVAVIA here. So this is one of the first NovaTalks that we are recording. And we are here today with Professor Chad Cook from Duke University. The idea was to, in this period of pandemic in which all of us are kind of isolated, to create some interesting content and discuss with experts from all over the world. They will be mainly our instructors, and Chad is one of them, and is also a friend. About interesting topics, something that maybe is not just strictly speaking, just clinical, but also a little bit more, can probably stimulate some thoughts. Hi, Chad, how are you doing?
Hey, I'm as good as can be expected. How are you?
I'm fine, thank you. So we know that also you in the US are living the same thing, so you're at your house as I am, and well, how are you coping with this, you and your family?
You know, it's a challenge. We watched Italy for I think you're a couple of weeks ahead of us with this, and we have similar trajectories. So as we saw Italy, we started to really worry in the United States. It's really troubling for certain areas, especially New York, Detroit, New Orleans. But I'm very lucky. They've handled it nicely in North Carolina, and we just have a few outbreaks.
Yeah, things will obviously evolve, hopefully. Well, let's stay safe and see how it goes. So long story short, what we proposed to Chad was sort of an informal chat on the evolution of the physical therapy profession. The idea was to contact him because, well, first of all, he's one of the most worldwide unknowledge advocate of our profession, and we've been discussing about this also in the past. We've been lucky enough to be in contact and to see Chad multiple times. I think you came with NOVAVIA in both Italy and Switzerland probably already 4 or 5 times. It was probably 6, 8 courses. I don't know. So am I right?
So, yes. Yeah.
And Chad became a friend. So that's why we're starting from here. And so, well, let's kick it off. I would start talking about the evolution again of the PT profession, probably starting from what APTA is the American Physical Therapy Association, what they did, and you guys did it started actually 20 years ago when they designed and discussed and approved the APTA Vision 2020 to evolve the profession towards direct access and other things that you are now going to talk about. So if you want to.
Sure. Yeah, thanks. You know, I'm lucky enough I've been a physio for 30 years, so I've watched this evolve over time. And I'm also lucky to have worked with, at the time, was the president of the APTA and one of the instrumental individuals in creating Vision 2020. And she tells me the story that she actually wrote down the ideas on the back of a napkin. And that napkin was the tool she used to help develop this. And a number of people developed concepts of Vision 2020. The idea was to elevate the profession. It was to elevate us as independent practitioners so that we could see the patients directly, that we played a larger role within the profession, and that we would move from being technicians, being told this is what you need to do with your patients, to be autonomous practitioners to allow us to treat patients. And interestingly enough, I think it actually succeeded probably in about 90% of the goals of Vision 2020.
Yeah, and I've been in the US for a while, and I know that not all the states are aligned at the same time. I think, if I remember well, Texas was one of the last one, because I've been in Texas for a while. Am I correct? It was just last year, 2 years ago, right?
The United States is unique. All 50 states have different practice acts. So the first thing you need to do if you move to a state is read the practice act, because you have different rights as a physical therapist depending on the states. We're now homogenous in that all states have direct access, but your autonomy within that state is different depending on which state you're in. Some states you can do essentially anything you want in that state, and you're reimbursed and you have access directly to patients. Others, you have to refer that patient to a physician in order to have direct access. It really depends on the state you're in.
Yeah, this is a big topic, I think, because direct access, so I'm now comparing this with Italy, for example. I live and practice in Switzerland, but I would keep it aside for a while. In Italy, there is direct access, yes, mainly in the private sector. But again, if you want to be, if the patient and you as a physio want to ensure that the patient get reimbursed at the end of the treatment, there has to be a doctor in between. So the diagnosis is a medical diagnosis, as it is in the US. We have been talking about this in advance before starting recording this. But what's the difference now? I think in some states, physios can also take care of the entire process with no doctor in between. I'm not saying doctors are not useful; they are. I'm just trying to discuss.
Oh yeah, and I know you're not saying that. You know, the type of patient that there is a consistent patient that probably doesn't need to see a physician, and this would be a musculoskeletal problem in which we have expertise. It depends on the insurance company in the United States. Some of the social insurance programs like Medicaid or Medicare, they're always going to require a physician to sign off on a prescription.
Yeah.
It's the private insurance companies or health system-based insurance companies, which we typically don't need to associate with a physician at all. And in that case, you see the person on day one, you manage their care, and then you discharge them when you think it's necessary.
Gotcha. So, and that was achieved in 2012, 2013, probably. So 2020 was sort of the expiration date, but they achieved the whole thing earlier, and they moved to another goal, right?
They did. I mean, it was a lofty goal. It was complicated. There was a parallel development of the educational system. We went from a bachelor's to a master's to a doctorate relatively quickly. And part of that ramp up on the education side was to reflect the Vision 2020 goals. And yes, I think it was 2013 that they actually developed a new vision for the APTA because they felt they met the Vision 2020 vision.
Yeah, I would like to talk about this because changing the education standards is a big, I would like to say is a big discussion. Maybe we are not there yet, but it's something I think we have been talking about this as well between me and you. But I found myself in discussion also at the university level about this. So now in Italy, for example, the bachelor is a 3 years degree. So that's it. After 3 years, you practice. And a lot of people are saying, and I also am a firm believer in that is too short, but also correctly, other people are saying, well, what's the point in making it longer if the quality is not elevated? So, I mean, that's probably the true discussion. So what happened in the US? First of all, how the physios cope with almost doubling the future physios, almost doubling the required years, because that means personal effort. So we want to advance the profession, but also we need to be ready to commit, right?
Yep. I got to tell you, there are pros and cons, just as you said, to increasing the years of your educational profession. And you know, one of the reasons we wanted to go to a doctorate degree was to compete with the other clinical doctorates: chiropractic, osteopath, dentistry, medicine. These are all clinical doctorate degrees, and we wanted to be at the same table as them and have a clinical doctorate. You're seeing occupational therapy do that in the United States. You're seeing nursing doing that in the United States, and even physician assistants are moving toward a clinical doctorate degree. So that piece, part of that is political, and part of that is having the clout behind your name to actually, so that you're not somebody's technician. Mm-hmm. But the challenge associated with that is that you increase the burden on the learner. It's now a minimum of 7 years of education before you can get out and practice. The cost associated with that is tremendous. That's lost salaries, lost wages because you're stuck in school, but it's also the debt, the tuition debt that's associated with that. And Sebastiano, one of the biggest challenges has been we have taken all of these individuals and we've required them to learn for 7 years. And a very small percentage of those are actually going on and getting PhDs. So now we're losing the educational, the professors, the future professors, those sort of things. Mm-hmm. Because fewer people are going to get their PhDs, fewer people are getting academic doctorates, and now there's a shortage of faculty.
Yeah, and also it would take too long. I mean, it would take probably 11 years or 10 minimum, right?
The money. Yeah, it's expensive, and who can put another 5 years on top of 7? That's a lot.
Yeah, well, that's a big difference between the US, in which universities cost, I mean, the amount of expenses you have to sustain are substantially different compared to, I would say, EU in general. It really depends, but it's completely different. So that is a point in favor of advancing the education length and also quality in EU countries, probably because it costs less. But yeah, another big thing about the APTA 2020 vision, that also Vision 2020, that also transitioned to the new vision, was evidence-based practice, in terms of not just a word that is in the cloud up there and we don't really know what that is, but as a clinician, to use it, perform it, and make sure the patient understand that, and also being advocate of not just our profession, but the fact that profession is evidence-based, or at least evidence-informed, right? I mean, we cannot always do what is written on papers, but at least we can maximize results, warranting that we don't invent anything or we don't try. So how did it go in the US? Because this is a big topic.
I think the new learner has been immersed in evidence-based practice since day one. So they're less opposed to following stricter guidelines on what is considered appropriate and what isn't. I think it was difficult for a lot of the old school clinicians who were really technicians. They did what they did in the clinic, they felt it worked, and they didn't want somebody telling them what they needed to do. There was a lot of resistance against that. So what we've done, though, is we've trained so many new clinicians that those who use evidence-based practice now are the majority. And you're a pariah now if you don't use evidence-based practice. So we've created a culture in which this is what we look for with EBP. And most individuals who really succeeded in the past based on their reputation or how well they marketed, those people they're moving out, not as popular.
Yeah, this is, we're a little bit behind, I would say, in that, but we're getting there. I think NOVAVIA, the purpose of NOVAVIA, as you know, because you have been one of the first cooperating with us, was diffusing the evidence-based practice culture, bringing in, as you are, clinical researchers, but also clinicians, or anyway, people that have been clinicians for a long period of time and then transitioned to be full-time researchers. Because not just because they want to publish, but because they saw the value in producing good quality research to support the practice of the clinicians. And but yeah, definitely there is the same sort of resistance that you probably experienced years ago, or maybe a decade ago, in which, but again, as you were correctly saying, the new the freshly graduated, the new graduate, they have a different mindset. They sometimes it's not even thinkable. They don't see any other option rather than, oh, let me see what the literature is saying first. That anyway is a good thing, because it didn't exist at all in the past. Would you say this went too far? I mean, sometimes here I got into discussions with maybe professional that trained years ago, say 20 years ago, 10 years ago. They said, well, it's too much. There is no longer the clinical reasoning. You're just relying too much on what the evidence is saying, but up to very extreme sentences such as you can find A and Z on PubMed, so it doesn't count. What do you think? What do you say about this?
I mean, it's a great question. I think it's how you assimilate evidence-based practice into your clinical environment. And we have to remind ourselves that there are 3 elements to it. There's the patient's preferences, there is the literature, and then there's the clinician and that clinician's knowledge. And it should be a marriage and an interplay of all 3. And when it isn't, and if you're relying purely on documentation or on publication, I think you're really not going to be able to do your patient the service that they need. In fact, we just published an editorial called Post-randomization bias. And we talked about the fact that a lot of randomized controlled trials are actually biased because of what happens after the randomization. There are so many papers that are just not worth the paper that they're written on. They just don't inform us in the clinic. You have to balance all 3. I think the big push now is on patient preferences and really looking at aligning care choices with patient preferences. I think that's going to be, over the next 5 years, there's where the momentum's going to be. But to get to your original question, I think it goes too far if you don't look at the balance of evidence-based practice and how that actually works.
Yeah, that probably leads to, correct me if I'm wrong, to your critical appraisal skills in terms of the school, also the universities, providing you not just the idea that you have to go through evidences or anyway. That's the first stop, but also you have to be able to filter them, because that's probably where everything is. I mean, where we should focus the most. Also, obviously about the other pillars, but if you understand when a paper is valuable or not, in that context, with that patient, well, you are probably going the right direction, aren't you?
Sebastiano, there are 3 million papers published every year, scientific papers. There are 36,000 low back pain papers published every year. There's just no way to be able to navigate that much information unless a person has some internal critical players of skills where they can sift through that large information. I think it's essential.
Yeah. So why don't you talk a little bit about the new vision of the APTA, considering what happened in 2013 when they decided, actually it was 2012, I read back yesterday, and then in 2013 they decided, okay, we have a new goal now, and it's a multi-composed goal. And do you want to talk a little bit about this? Because again, it's in line with evolving our profession.
I'll give you some backstory on it. The profession felt that we needed something that was ours. We needed a way to define what we did. We needed to be able to say we are about, and what they selected was movement. They said physical therapists are experts in movement, and they tried to build the vision around our contributions to healthy lifestyle associated with movement. So the new vision is about optimizing society through human movement, and they have really pushed that movement is good, activity is good, you should see a therapist to help promote that movement. And that's where we are right now with respect to that. And I feel pretty good about it, but there are some things that I have concerns about.
Yeah, that was probably where I was going to ask you further questions, because obviously this is sort of creating a big paradigm and probably a paradigm shift towards manual therapy, for example. If you think about the manual therapy schools and what manual therapy has been for a long time, and obviously manual therapy has a value, but when I remember very well when I was in the US, and I still have a lot of friends in the US that they practice, and at the beginning of my career I was asking them, so what do you think about this training or this course? And the replies from them was almost the same. It was, there is no movement there. I don't see the value, because you need, I mean, it's everything. The only thing that matters is that one. And here we were still behind, I think, in Europe, I would say, but maybe Asia as well. I don't know. I cannot tell. In terms of, we need to have our skills in our hands. Our hands are the most important things. They are surely important, but are your concerns related to this dichotomy maybe? Or I don't know, is it too much? It's not only movement, maybe that's what you were talking about?
Well, yeah, to me, it's not only movement. Yes, we are experts at movement, absolutely, but there are some people in which movement is the one thing that makes them worse. Movement of pain. I think pain science and a lot of the contributions on that end, they don't always deal with movement. They deal more with about cognitions and reframing how people think, reframing expectations. All of these are not related to movement at all. I think we're more than movement. And with respect to manual therapy, if you only use manual therapy as your gateway to movement, I think you make a mistake. But I think manual therapy can be used as a catalyst to promote movement. And that's where I think its value lies. It's both pain modulatory and it's a catalyst to movement. But that movement that occurs after that initial stage, that has to be more active, has to be more promotional, that has to be more lifestyle oriented. And I do think physios do a pretty good job with that.
This is something I'm sure we discussed about, actually, because I used to be your interpreter in many of your courses, and then we discussed about this, I think it was like 3-4 months ago, when I happened to have to deliver a speech about this, and we talked about the percentage. So if you want to oversimplify, and this is, just to be clear, an oversimplification, and you have to say, okay, manual therapy versus, and it's not a versus, manual therapy and movement in percentage. Would you say the 5-10% it's approximately is decent approximation of how much of manual therapy you should perform on a patient on average, but that doesn't mean it's true. I would say on average, it might be 100% with a patient and 0% with another one, or not.
Yeah, on average, I think, because I've created a pyramid where I think only about 10% of people absolutely need manual therapy, and you can get by with something else if you wanted to. But I would say that if I had to invest time into somebody and movement was my goal, maybe 20% of effort might go toward a manual approach and more 80% toward either an active approach within the clinic or spending some time and talking about a person's own active approach outside the clinic. But it doesn't mean that I think the beauty of this, and I think you know this, is that the wonderful thing about manual therapy, that may be the catalyst that gets that patient.
Mm-hmm.
And if we can break through that wall and that limitation for that particular patient, that may be the one thing that works, but it doesn't have to be the only thing.
Yeah, it might be the key to open the door, and then you can actually rely on movement, the movement that was lacking. No, I agree, absolutely. So again, in terms of, so you're an advocate of PT profession and the evolution. We could talk about this for hours, I would say, but to focus on mainly probably 2-3 topics. One thing I would like to ask you is, okay, we discussed about what was done in the US, and then there is the rest of the world. People are doing pretty good job, I think, worldwide. Some countries are a little bit far ahead than others, but how a physio himself or herself can be an advocate of our profession. And also, I would say, I don't want to say in a more egoistic way, but there is nothing wrong about it. If you are a physio that works in his own PT clinic, and you and another physio, just a small clinic, you have to make sure that you have patients, right? And so how do you promote the profession with patients, with doctors? I mean, yeah, on a broad sense.
Yeah, so I think it needs to be, so I see two different answers in what you stated. The first one is, how do you promote the profession? And I think one of the things that we did well with the APTA is that we had enough key individuals, enough leaders that actually bound together and made the APTA very strong, and to the point where we did represent the profession. So there was a strong central source of leadership, and everybody tended to gravitate toward that and really support that leadership, right? In the countries that are behind, I see that there's a leadership vacuum in many cases. There's not a central source or a governing body that is really that can really help stabilize and promote the profession at a different level. At the day-to-day clinical practice level, I think it needs to be patient-centered, so that when we communicate with physicians, when we communicate with community leaders, when we communicate, it's always patient-centered. That the reason we do what we do is for the patient. It's not for us. It is to promote the patient, to promote their healthy lifestyle. Here's how we fit in. This is what we're doing. Here are our successes. Here's what the patients need. This is how we do it. And I think by doing that, you start to speak the same language that a physician speaks or other professions. We're all in this together, and it's for the patient. This is the first time in the United States that I truly believe that all the health professionals are doing things more for the patient than they are for their own professions. And what you're seeing is the movement of the chess pieces now that is built around why this person's in charge of this and this person does this. It's because it's best for the patient. And I see that evolution is happening. Canada, they did it before us. Australia, New Zealand, they did it before the United States.
Yeah.
Migrating now and moving.
Yeah. So I have two specific questions, and we can chat a little bit about this. Towards patients, or with patients, how can we be advocate of our profession with patients and with doctors? And when I say doctors, it's a broad term to include, obviously, GPs, so general practitioners, up to surgeons. So starting from the first so the patients, too often I think we miss, but this is my position, so I want to discuss this with you because obviously that's what interests the people are watching this interview, this NovaTalk actually. Should we describe a little bit more to patients what we do? Because what I found interesting is that also from qualitative research, if you check qualitative research, it says it quite loud, that patients want to be informed and they can manage information. They are not a piece of wood there. I mean, they are alive, they have their own brain, and they can cope very well actually with informations, even if these informations are, we don't know where we are going. Prognosis wise, I cannot tell you. Let's see how it goes, or realistically speaking, because this is fair. So at the beginning, you are communicating with another human being, and you are a human being. And I mean, as a former patient, long-term patient, as I used to be, you need that. Sometimes you need certainties, but if these certainties are false, if they are just not based on nothing, they will anyway fail. So it will be even worse. So also sharing what we do based on evidence with patients. Do you do this? Do you advise to do this? Because it's something that I think is important. That we have this solid evidence that's saying this. Let's go this direction and see together how it goes. And so to understand also what patient thinks about it. Sorry.
No, this is my favorite question that you've asked, because I think there are two ways we could go down on this one, right? You could either go down the traditional pathway in which we tell the patients a bunch of bunk, a bunch of nonsense that's related on old theories and dogma, and then we end up sounding ridiculous to our physician colleagues and to researchers and others because we're advocating something that we heard in a Con Ed course that has no validity, no legitimacy whatsoever.
Yeah.
I do not recommend that. However, it does mean that we're going to have to be knowledgeable enough that we can communicate with the patient appropriately. Now, you had a very complex situation in your particular case. So I imagine a lot of your clinicians were treading water. They didn't quite know what to tell you. But the average patient, we should know exactly what to communicate with them. We should know what the typical prognosis is for non-specific low back pain. And we should know exactly what to tell them with respect to tissue, with respect to activities. We should be very informative and engage them and make them part of that process of care. But the key is we have to be educated enough to do that. Yeah. And a lot of us aren't. And that's the challenge with physio is they fall back on this old knowledge that isn't correct instead of the new, more evidence-based knowledge that can really guide things much better.
Yeah, that was the point for my question, and it's connected to let's say there is a red line in between the evolution of the education system in the US and how can you actually provide a better healthcare, delivering better, service to patients. And yeah, absolutely. And the other part is doctors, let's say surgeons, and let's say we talk about musculoskeletal rehabilitation, so orthopedic doctors, sports medicine doctors. There is I don't know how to describe that, but let's say a lot of physios, at least that's the pulse I have, think we are on different sides of the river, but not just a river that is dividing to, again, two sides, but two countries. I mean, and there is no bridge, and it's not even worth trying because I tried once and it was horrible, and that's it. I mean, I think again we're human beings, and you can even try to, with a girl, and it doesn't go well, but that means it doesn't stop you from, pursuing your target. So again, they are human beings, and what I've been experiencing, and this is the question that I want to ask you, is reach out for surgeons, go in the OR, share their own word, because they don't have a lot of time, to be quite honest. So either you go where they are practicing, because literally sometimes they operate 10 hours per day. They just don't have time. It's not fair. We don't have time either, but we need to make a choice. And if you create connection, and if you are prepared, if you're not prepared, you're out of the OR in 20 minutes probably, or anyway one day, and it's not good. Then you can really bond, create a bridge, and then it's a completely different practice from them on, because then you share with the doctors the plan, and it's, even if it's not written, it becomes direct access. You know what I mean? So it's a transformation that you can make happen in advance. What do you say about this? Because I think this is a hot topic in Europe.
First of all, I completely agree with you. I'm in the Department of Orthopedics at Duke, and my physician colleagues work 60 to 80 hours a week in the clinic or in surgery. They do not have time.
Yeah.
When I meet with them at about 5:30 in the morning or on the weekend. But they have told me They want one of two things.
Yep.
They want to make sure their patients are taken care of with smart, effective, reasonable techniques in an environment where the patient is happy, so that when they go back, they say, thank you for sending me to that physio. The second thing is they want to make sure that you don't hurt the patient. They don't make the patient worse. That you don't tell them false things that will alter their recovery process. So you don't say negative things about the physician. You don't say negative things. They don't want to be your combatant. They want you to be their colleague. So I think if you cover those two things, the patient becomes your marketing source to the surgeon.
Yeah, I think that's really crucial, especially here. And I do recognize that there are barriers and there are cultural barriers, and probably we are a little bit behind. But good doctors are out there, and it's the same for us. We have the youngest that are trained probably in a slightly different way, and then probably someone that got trained 10, 20, 30 years ago, it's not on the same page. But it's not necessarily true. Sometimes you just talk with a surgeon that's a 60 years old surgeon, and he knows absolutely what has to be done, and he was actually starving for you to come. And it's true story. Sometimes they said, oh, it's the first time a physio asked me to come in the OR. Welcome. It took 30 years, and it's a good thing. So I think it's up to us. I think sometimes we wait a little bit too much for it coming from somewhere else, someone else, depends.
Yeah. When I was the director of rehab I had 7 outpatient clinics for a hospital system. And weekly I would go out and meet with the physicians and try to just communicate with them. Even if it was a 5-minute conversation, it just keeps you connected with that potential referral source.
Yeah. And in fact, it's also good business-wise. It's something that in the US we can talk about this with no problem. Sometimes in other cultures, talk about business and healthcare in the same situation when you're taking care of someone sounds like a little bit egoistic, but that's true. I mean, again, if you have your own clinic, you have to, it has to work. Otherwise, you have to close the clinic. So in the updated vision of APTA vision, there was a thing, it was an item that was sort of framed the physios of the future, present and future, because we're talking about 7 years ago vision, as forward thinkers in terms of delivering healthcare potentially in different ways. That was something really, I remember that, but I didn't remember the description itself. So knowing that we would have been together today, I went through again and I found it fascinating because it was there 7 years ago, and now we are going through what we are going through with this pandemic. Obviously, no one knew. But I think it's interesting always, whenever it happens in every field, when someone sees things, or at least that might be necessary to think in a different way in advance. So now there is a big talking about telehealth or telemedicine. And I tried to develop some discussion on the social networks, and I would say that again, in return, sometimes you got something like, how can I be a physio with a screen in between? I cannot use my hands. The hands are the most important things. And this leads to, so tell me what you think about it, and then we'll discuss, because I think this is a very important topic for the future.
I'll tell you this, the first time I really thought about telehealth for physical therapists was in 2015, when I was sitting across the table from Kim Bennell from Australia, who was telling me the results of her studies, and she said they actually had better patient rapport, there was better communication, and the physios felt they did a better job with telehealth. And I was just like, I can't conceive that. I just felt like there was no way that could actually work. Well, we started a trial in 2017 where we actually give cognitive behavioral therapy through telehealth. And we just published one paper, and we have just completed the data collection on another paper where we actually looked at examination accuracy with telehealth versus a clinical examination. And the telehealth one for the hip was actually more accurate. For the shoulder, it's actually the same. So the more we find out using telehealth, the better value it seems to have with patient. And think about, I mean, now's the perfect time, right? But even if we did a pandemic, think about all your rural people. Think about all your individuals who have health access problems. Think of all those individuals who can't get in a car or a bus and go to your clinic. You can still manage those individuals through a telehealth approach. So I'm a big fan of telehealth. I think it's actually quite useful.
Yeah, I wanted to bring it up because because of what we are living now, obviously. I think society all over the world most of the time moves to A to B because it's forced to, because sometimes we are not enough forward thinkers as we would like to be. But certain countries, and I would say in this, having lived in both continents, Europe, I mean, history in Europe, I mean, it's an older country. And I say country when I considering European Union. So it's an older place, so more radicated, rooted thoughts. And US, it's younger place in general. I mean, history is on the table, right? So what I found always interesting in the US was that everything was possible in terms of, even if it was never been done before, is it worth, maybe let's even try, run a study and see how it goes. But let's give it a try. And but sometimes here there is more resistance. So it was a topic to be discussed probably. Have you used telehealth before with some of your patients, for example? Let's say not in the pandemic. I know you just introduced your study, etc. But yourself before earlier than 2015, maybe with someone who was traveling, an athlete, whoever, and you found it useful or not? Did it happen to you?
No, the trial was the first I used telehealth. That was so it was new. I had to be trained up on it. We actually had a behavioral therapist that actually worked with me to make sure that I did it appropriately. But no, I hadn't done that before. I had emailed my patients. I had texted my patients. Technically, that is part of telehealth. But when I see telehealth, I see it as a more organized method of engaging the patient. It's more than just emails and text messages.
Yeah, and probably this brings to what I had in mind in terms of we need to be trained to do so. I mean, we're not ready. We need to be humble enough in saying, okay, again, commitment, effort to possibly know if it's worth it or not. And we already know probably that it's worth, but we need to put some effort ourselves, because otherwise it will be just, you try and maybe it's not going well, but it's just you. Maybe you're not good enough in communicating or in delivering the healthcare as you should.
So I just tweeted a reference to a paper that actually talks about this. Here's how you need to develop yourself as a skilled telehealth practitioner. Here are the key principles. And so people are thinking about this and making solid recommendations. I agree, we need training.
Yeah, I was referring to that tweet actually, and also was referring to the fact that for total knee replacement, for example, we have had studies that showed that was unthinkable for MSK physios. Like, oh, they do the same or even a little bit better at home with a screen in between. I'm not touching them, and it's a total knee replacement. It's quite interesting. Let's put it that way. Someone would comment, "Oh, it's bad for us as a profession, but maybe we should twist the way we see things and see it as an opportunity or similar."
I think it's an opportunity. I do have some concerns about it. Most of the states in the United States do not have parity, so they do not pay the full amount for a telehealth visit. They only pay a portion. And I don't understand why, if you're delivering a comparable care option, why it should be just a small percentage of what they would receive if they came in live. But once that's all sorted, I do think that it's going to be a pretty strong option for the future. Most of the physicians really love it. They're all using telehealth now because of the pandemic, and they're shocked at how effective and efficient it is. And I think it's something that we have to look forward to as we move, as we progress as a profession.
So I'm pretty sure we were together in Florence when you introduced the 3-4-50 rule. Do you remember about this? Because the 3-4-50 rule, the state of Vermont made, I think it was a study in the US, in which they demonstrated that there are three main factors that are tobacco use, not enough physical activity, and a poor diet that are leading to the four, more diffuse diseases that are leading to more, actually higher than 50% of deaths in the state of Vermont. this is probably the big argument for the telehealth as well, because these are the, isn't it? I mean, these are the patients that we can educate. Do they need to see us? I mean, absolutely happy to, but, or sometimes if there's a barrier in between, no money, 200 kilometers or miles, whatever, maybe that's the field in which the whole thing can flourish. What do you say? What do you think? Do you remember? He was in Florence, I'm pretty sure.
Yeah, that's a heck of a memory you have. Yeah, I just now remember that. I think that's actually the last time I actually commented about that. But no, I think there is a select population that will actually be better, that's really going to capitalize with telehealth. You know, I think about a vestibular patient from home, because often to find an expert in vestibular rehabilitation, they have to drive two hours, something of that nature. It would open the door for those individuals. Women's health is another. I mean, just getting experts in front of patients that they would normally have that expertise, I think is really important. In the United States, there's actually a shortage of orthopedic surgeons. So getting orthopedic surgeons in front of patients, I think is going to be a boon for telehealth. But absolutely, I think there are a lot of positives. My biggest concern is if people don't know how to do it well, and they're wasting the patient's time. And it's almost like home health. The home health really blew up for a while in the United States, going to the patient's house, delivering care there. But there was such bad care provided. We need to wrap our arms around what the right type of telehealth care is, and then facilitate that.
Yeah, I think that is the most important thing now. I mean, we could, the whole thing could flourish. It could show the potential that probably it has, or in certain countries or all over the world. If practice it in a wrong way or with no skills enough, it could be the opposite, and that would be waste of time and waste of opportunities. So, but it was worth mentioning and talking about this, in my opinion, because of the time you're living in, and also because a lot of discussions are ongoing on the social networks, and physios are at home, not working. I'm thinking about Italy. It has been a long time. So my thoughts and I would say feelings are going to all the colleagues and their families, because I do live in Switzerland, but I am Italian, and my wife is now in Italy. So it is anyway my country. And it has been weeks. And after, the first week is, okay, we can cope with that. And then after a while, you start to be worried. You don't see the horizon. Where are we going? So processing new opportunities, and maybe get trained online. There are a lot of free courses on, I'm not going to name any course providers because it's not fair, but they are free. A lot of universities in the US, universities worldwide, and they just decided that it's free for 1 month or 2 months. So you can get a lot of education on something that apparently is not useful, but maybe it will. So that's why.
That's really good advice, Sebastiano. I think, I do think the training is necessary, and it's the free. Some of those free resources like Coursera and other things, these are top-notch providers, top-notch educators. You might as well take advantage of it.
Yeah, I didn't want to mention, but I was thinking about that, because anyway, behind Coursera, there are the top-notch universities that are providing courses for free, and it's amazing.
Including
I think. I'm sorry. Yeah.
University.
Yeah, I saw it. The idea of the NovaTalks is this, and I wanted to share it again with you, with all the people that are watching this, and I hope they will be a lot, is that we could talk about clinical topics, but we felt it was, maybe it's worth it. We will do it. But again, you're at home with your family, you're not seeing patients, and maybe you're also a little bit frustrated. And so the idea was, why don't we do something slightly different that can open minds, possibly, and also can lead people to say, okay, then maybe I'm going to invest 4 hours on that course, or I will buy a book, or oh, look, I have the book, but it's been there for 3 years, because that's what happens, right? We buy books and then they're just piling up and we have no time to read them. So that was the main purpose, and we thought that starting with you, it would have been, well, the best. So turned out it was, I hope. How was it for you? Because that was different, I guess.
I enjoyed it. When you approached me, obviously one of the best values is just having a conversation with you and catching up. I know that you've been in a tough situation being with your wife in Italy and you
Yeah,
in
we
Switzerland.
all are. We all are. I mean, it's
Yeah, but I tell you, here in the United States, we're watching Italy closely. Our hearts are with Italy. We really feel for you and some of the other countries in Europe that are really struggling. We're starting to see it now, so we know exactly what it's like. It's surreal. It's just surreal. So if there's any way that having a conversation connects with people in Italy and elsewhere so they can feel human again, I think it's a wonderful thing.
Yeah, thank you. We really appreciated that, and we appreciate that you accepting this invitation. Again, probably we started with you also because of the relationship we built along the years, and it's obviously a gift. So thank you. I'm not excluding we are going to bother you again in the future. I don't know. It depends how long it will be. Unfortunately, it looks like it will take time. So we will see. So Chad, thank you very much for your time. That was, I think, hopefully it was a useful thing for everybody. For me, it was.
Thank you for having me on.
Okay, thank you. And that was Chad Cook from Duke University on this topic that mainly we thought was useful to discuss. So the evolution of our profession, starting from the US experience and what is happening around the world in this pandemic period. Thank you guys, and see you soon.